there at the bottom, all of these are the first generation. They're looked at as low potency and high potency. The first two that came out were chlorpromazine and thioridazine, Mellaril and Thorazine. They've been around for a long time, probably 50, 60 years. And they are kind of in their own category. They have lower incidence of some types of side effects compared to the higher potency, which are the ones below them. So that's the first generation. On the next page, there is the second generation. And they do have different effects on receptors. So all of the antipsychotics will affect dopamine receptors. The second generation have much more effect on serotonin. So they also affect dopamine receptors, but they also affect serotonin. And it's thought the fact that they are more serotonergic, less dopaminergic, is why you see less extrapyramidal side effects. The other is the second generations tend to not sit on the receptor as long. They tend to sit on the receptor and then they get off. And so it's thought that that rapid disassociation, more serotonergic use, is why we see less EPS and less tardive dyskinesia. So this is showing you the range. You'll see there's quite a few of the second generation. You'll see that they have different effects and affinities for different dopamine, the D2 or the D3, and then the serotonin receptors. At the bottom of the page, it gives you a picture of the first generation agents and their affinity for the D2. Both of these, all of these, will also affect histamine, muscarinic, and alpha-1. So if they hit histamine receptors, then what are we going to see? Sedation. So a lot of these drugs are going to be used for their sedative effects. So what do we see in the movies when somebody is acutely agitated? What do? They give them a shot. So they're usually using it like a Haldol or something along that line. It's because they are rapidly calming, rapidly sedating. What about the muscarinic? What side effects are we going to see there? So that's the anticholinergic. So dry mouth, blurred vision, constipation, bladder or urinary retention. And then the alpha-1s, then we're going to have cardiovascular, so orthostatic hypotension. Now, all of these drugs will have some degree of effects on those receptors, but their affinities for them will be different. So this is where you will see the difference. Some of them have little to none effect on histamine receptors. Some have little to none on muscarinic. So that's how you can use that knowledge to choose different agents. Or if they're having trouble with one set of side effects, you move them to a drug that has less affinity for that receptor. Okay. If you look at on page 3, it shows you the affinity or the affinity for the D2, same as we see with the first, and then we're adding in that serotonin 2A. There's a ton of serotonin. There's probably 5 or 6 different types. There's probably even more than that we don't know. The bottom shows you that rapid dissociation. So it gets on the receptor, sits there for a little bit, then gets off. Okay? And then the dopamine can get back. So if we sit on that receptor long enough, what side effect do you think is going to happen from depriving them of dopamine for a while? Tremor, what else? Parkinson. So a drug-induced Parkinsonism is common with this class of drug. See how it all starts to fit? You know stuff, you can put it together. Okay. So on page 5, there's a little summary there of the first and second in terms of mechanisms and other effects. If you look at the bottom of page 5, I like this because it shows you the difference in high dopamine receptor occupancy and the risk of EPS. So you see the antipsychotic effect from that dopamine interaction, receptor interaction, is at the lower end. And when you move up into higher association, you tend to get the EPS, but you get no further antipsychotic effect. Okay, so that's why it's important to be cognizant of dose. And what you'll find out, a lot of these drugs have been around forever, so the dose that's published was what was based on the early data that the company had when they filed with the FDA. What you'll find a lot in the literature now is that they're using much lower doses, they're getting the effect, but they're avoiding more of the EPS. Okay. So you may note that difference if you're looking up the dose and then you're seeing what others recommend. On page 6, side effect profile. First generations, more neurologic. That's the EPS and the tardive dyskinesias. The second, it's the metabolic side effects. And we're going to go through each of those, and they are significant. Do you need a break, or can you go a little bit longer? It's about 3:30. You want a break? Okay, we'll take a 10-minute break.